Good afternoon. Today we are going to read the anaphylaxis guideline from the Green Book. We start with the definition of anaphylaxis. What does it mean, anaphylaxis? It means sudden onset, systemic life-threatening, hypersensitivity reaction. Triggers may be food, drugs, antibiotic, non-steroidal anti-inflammatories, chemotherapy, contrast material, anesthetic agents, even insect sting, latex, involves one or more of the following. Acute onset illness from minutes to several hours involving skin and or mucosal tissue with one of the following. So it's essential to involve the skin or mucosal surfaces with one of the following: respiratory compromise, reduced blood pressure, or symptoms of inner organ dysfunction. Two or more of the following after exposure to a likely allergen from minutes to several hours: skin or mucosal involvement, respiratory compromise, reduced blood pressure, persistent GIT symptoms, reduced blood pressure after exposure to known allergen from minutes to several hours. For infants and children, low systolic pressure according to age-related values or decrease in 30% of systolic pressure. So for infants and children, we can consider the systolic blood pressure is low according to the age related value. There is a timetable, or if there is any decrease in about 30% of the systolic pressure. For teenagers, systolic pressure less than 90 or decrease more than 30% of the baseline. Okay, what are the symptoms and signs? We start with the skin. It's going to be itchy, red, hives or swelling, oral and nasal mucosa, itchy nose, swelling. In the conjunctiva, it's going to be itchy as well, swollen, and red. For the respiratory tract, hoarseness, throat itching, tightness, stridor, cough, difficulty breathing, chest tightness, wheeze, even cyanosis. For cardiovascular, tachycardia, chest pain, hypotension, weak pulse, dizziness, collapse, shock. For the gastrointestinal tract symptoms, nausea, cramping abdominal pain, persistent vomiting, and diarrhea. For the central nervous system, behavioral changes in infants mainly, sense of doom, headache, altered mental status, confusion, and tunnel vision. Okay, so what's the immediate treatment in this situation? It's an emergency and it's life-saving. Okay, we're gonna go to have a look on the management of anaphylaxis algorithm. But before we go to the algorithm, we have to know the initial steps. First, we have to remove the allergen if possible and call for help. Ambulance, people in the place where you are, ask help from them to call the ambulance if you are doing resuscitation at that moment. Adrenaline IM if available, dose by age or 10 microgram per kg using 1 in 1,000 strength, 0.01 milli per kg of 1 in 1,000. Give in mid-outer thigh. Auto-injectors may be used as well according to the age group. Less than 6 years, 150 microgram, 6 years to 12 years, 300 microgram, more than 12 years, 500 microgram. Do not give adrenaline for widespread facial or peripheral edema and rash in the absence of other systemic symptoms. So if you have only skin symptoms That's rash and itchy, so do not give adrenaline in this situation unless you have respiratory and cardiovascular manifestations. ABC approach is crucial in here, provide the basic life support as needed. Facial edema should prompt careful review of the airway. It could be associated with airway swelling and stridor as well. If airway edema, call anesthetist for potential difficult airway intubation. If not responding to adrenaline IM, give nebulized adrenaline 1 in 1,000 concentration, that's 400 microgram per kg, maximum dose 5 milligram. So if there is no response to adrenaline IM, you give nebulized adrenaline. Okay, treat shock with sodium chloride, normal saline 20 ml per kg bolus. I highlighted this in yellow because it's been changed in the new guideline, the recent guideline. I will share it for you later. Actually, I have it in here. So we have, this is the new and recent anaphylaxis guidelines. We have in here the little box down here for the IV fluid challenge. Use crystalloid in children 10 ml per kg. So the recent change is 10 ml per kg and not 20 ml per kg. And it's written in here in the green book. So keep that in mind, okay? And keep yourself updated with the guideline every time. Okay, and next we have to monitor the SpO2, non-invasive blood pressure, and ECG as well. So we need to monitor the oxygen saturation and non-invasive blood pressure and ECG. If no response after 5 minutes, you repeat the adrenaline IM. If no response after 5 minutes to the second dose IM, give IV infusion, 1 microgram per kg, maximum 50 microgram, and sodium chloride, 10 to 20 ml, infused slowly over 1 minute. Okay, so we have the note in here in the box. Do not give adrenaline IV except in cardiorespiratory arrest or in resistant shock. No response to 2 IM doses. So keep this in mind. Okay, what's the subsequent management we have in here? Admit for a minimum of 6 hours to detect potential biphasic reactions and usually for 24 hours, especially in the following situations. So we have two options, whether we can admit for observation for 6 hours or for 24 hours. So we admit for 24 hours if we have a severe reaction with slow onset caused by idiopathic anaphylaxis. If there is a reaction to individuals with reactions in individuals with severe asthma or with severe asthmatic component, or reactions with possibility of continuing absorption of allergen, patients with previous history of biphasic reactions, patients presenting in evening or at night, or those who may not be able to respond to any deterioration. Patients in areas where access to emergency care is difficult, we have to monitor the oxygen saturation, SpO2, ECG, and non-invasive blood pressure as a minimum. Sample serum clotted blood must get to immunology immediately for mast cell tryptase at the following times if clinical diagnosis of anaphylaxis uncertain and reaction thought to be secondary to phenom, drug, or idiopathic. So we have to take a sample for mast cell tryptase immediately after the reaction 1 to 2 hours after symptoms started, when levels peak, and more than 24 hours after exposure or in convalescence for baseline. So this is very important. We have to obtain a clotted blood sample for mast cell tryptase um, 3 times. The first time immediately after the reaction. The second one, it's 1 to 2 hours after the symptoms started, more than 24 hours after exposure. If patient presenting late, take as many of these samples as time since presentation allow. Okay, what's about this discharge and follow-up? Discuss all children with anaphylaxis with a consultant pediatrician before discharge. Give following to patient or as appropriate their parent and or carer. We give them information about anaphylaxis, including signs and symptoms of anaphylactic reaction. It's basically a leaflet to read about the condition and to get some information and knowledge about it, as it's going to be standby with the child for a period of time, so they have to be familiar with it. Information about the risk of biphasic reaction, they should know about that and they should be aware. Information on what to do if anaphylactic reaction occurs, use adrenaline injector and call emergency services. Demonstration of correct use of adrenaline injector and when to use it. Advice about how to avoid suspected trigger, it's very important. If it's known, it's better to advise parents to try to avoid this trigger. Information about need for referral to a specialist allergy service and the referral process. Information about patient support group, it's very crucial. Discharge with an emergency plan, and it's very important to mention the emergency plan, including 2 adrenaline pen auto injectors after appropriate training. They put on in here a link, British Society for Allergy and Clinical Immunology, pediatric resources. There's in here a link, you can click on it and it will take you to the page. If still symptomatic, give oral antihistamine and steroids for up to 3 days. So I highlighted this with blue, with light blue, because it's very important to know that there's no steroids rule in the early management of anaphylaxis. You can only prescribe steroids on the discharge of the baby or the child with the antihistamine if there is ongoing mild symptoms. You can prescribe steroids and oral antihistamine. Otherwise, no rule for steroids in the early management of the anaphylactic shock. So think about steroids on discharge. And we give it for up to 3 days. Refer as outpatient to consultant pediatrician with an interest in allergy. Okay. So in here we have the algorithm of the management of anaphylaxis. It's like it summarizes what we have read so far. It's put all the puzzle together. First, assess, call for help, remove allergen, face mask oxygen, adrenaline IM, assess again. If there is no problem, you will assess further again. No problem, he is doing well, assess for the 3rd time. There is no problem, reassess the ABC, and if he is doing fine, you discharge him. Okay, so that's the middle line. So what if there's part obstruction stridor, which means that's partial obstruction of the airway. If no response, repeat adrenaline IM. So Basically, we give adrenaline IM immediately. If no response after 5 minutes, we have to repeat the IM adrenaline injection. Think about adrenaline nebulizer every 10 minutes as required. In here, they mentioned hydrocortisone IV. So in the hydrocortisone IV, I'm not sure about this point because they mentioned earlier that we give only steroids on discharge of the child, and in the new guideline, they mentioned that no role in steroid prophylaxis and steroid use in the early management of anaphylaxis. I will get that page for you from the new guideline right now. Just give me 1 second. All right, guys, this is the recent anaphylaxis guidelines, which saying that the antihistamines are considered a third-line intervention and should not be used to treat ABC problem during initial emergency treatment. Just keep that in mind. Okay, what is saying in here about these steroids? Corticosteroids, hydrocortisone are no longer advised for the routine emergency treatment of anaphylaxis. Okay, so you can offer these steroids only on discharge up to 3 days if there's ongoing mild symptoms, just to get rid of it, but do not use the hydrocortisone in your initial management together with antihistamine. Just keep them if you need in the discharge prescription. Okay, that's what I was going to show you. Back to the algorithm again. Okay, in here, so that's to clarify this point. Please, guys, if there's any mistakes or misunderstanding of the guideline, just don't hesitate to comment down below this video, and we all learn from each other and we can share knowledge together. As I'm preparing for a clinical exam as well, so I'm not very you may find the information and there's some mistakes or anything, you can correct any piece of information that you feel that it's not it's inaccurate. That's absolutely fine. You can comment down below and let me know about anything that you are unhappy with. Okay, so next we have the if there is still upgoing wheeze, if no response, repeat adrenaline IM, adrenaline nebulizer every 10 minutes as required. They mentioned hydrocortisone IV in here, and we commented on that before. Salbutamol IV or aminophylline. In the new guideline, they still mentioning the salbutamol IV and aminophylline. That's absolutely fine. If he is in shock, if no response, repeat adrenaline IM together with the crystalloid. We said it's going to be 10 milligram per kg. Adrenaline IV infusion as well. Okay, let's go to the last line in here. If we have a complete obstruction of the airway, so that's intubation or surgical airway. If he is in apnea, bag mask, ventilation, adrenaline IM, hydrocortisone IV, if no pulse, basic and advanced life support that he needs a resuscitation, and then you have to reassess the airway, breathing, circulation once again. Okay, this is the last page of the anaphylaxis guideline in the green book, mentioning the drug in anaphylaxis, which is the adrenaline, the adrenaline IM, in pre-hospital setting and in a hospital setting. the adrenaline IV dose, the crystalloid, and the hydrocortisone, whether IM or so IV. So the pre-hospital setting adrenaline IM, it's according to the age group, less than 6 months up to the 5 years, 150 microgram, 6 years to 12 years, 300 microgram, more than 12 years, that's 500. In adrenal IM in the hospital setting, that's 10 microgram per kg. Adrenal IV is going to be calculated 1 microgram per kg if you are using 1 in 10,000 strength over 1 minute. So you have to double check the strength because what's available in your workplace, whether it's 1 in 1,000 or 1 in 10,000. So you have to double check again with the nurses to get the true ampule that you need to. Crystalloids, they mention in here in the green book, it's 20 ml per kg, but as we mentioned before, it's been changed to 10 ml per kg. Hydrocortisone, IM or slow IV, it's according to the age group as well. We mentioned that in the recent guidelines, they remove the hydrocortisone from the true management of the anaphylaxis. It's only given on discharge if needed. But if you're interested to know the doses for the IV and IM injections, it's over here in this table. I finished the guideline of the anaphylaxis from the green book, but we can, I want to share with you the algorithm from the new recent guideline, which published from the Resuscitation Council UK. It's very simple and straightforward. It's like a revision for what we have said before. So in anaphylaxis, we have to manage the airway, breathing, circulation, stability, and exposure. Diagnosis, looking for sudden onset of airway and or breathing and or circulation problems. That's my main thing to start with in these situations. Usually skin changes, itchy rash, call for help for sure, don't forget, call resuscitation team or ambulance immediately, remove any triggers if possible, stop any infusions. The thing that they add in here that you have to lay, the position of the patient itself is very important and crucial until the ambulance arrive, the Medicare arrive. You have to lay the patient flat with or without legs elevated. A sitting position may make breathing easier. If pregnant, lie on left side. So this is the right position you put the anaphylactic patient in. So this, you will maintain the circulation going up to his brain. Whether this position or this semi-sitting position, never let him stand up, never. Okay, don't try to lift him up and let him walk or stand. You will make this the situations more worse. Okay, and you have IM adrenaline injection in place. You inject it in the anterolateral aspect, the middle third of the thigh. Establish the airway, give high oxygen, flow oxygen, apply monitoring if you have in place, a pulse oximeter, ECG monitoring, blood pressure is very crucial. If no response, you repeat the IM adrenaline after 5 minutes, IV fluid bolus 10 ml per kg, as we mentioned before. If no improvement in breathing or circulation, despite 2 doses of IM adrenaline, confirm resuscitation team or ambulance has been called, follow refractory anaphylaxis algorithm. So in here, as you notice that they did not mention, we have to use the adrenaline nebulizer while in the Green Book they mention you will use the adrenaline nebulizer. Let's finish the algorithm and check. So we have another algorithm for the refractory anaphylaxis management. The next set page in here, I have to rotate it many times to get it in the right place. Just give me one sec. Yes. And here we have another algorithm for the refractory anaphylaxis. No improvement is what does it mean, refractory anaphylaxis? If there is no improvement in respiratory or cardiovascular symptoms despite 2 appropriate doses of IM adrenaline. So in here, establish dedicated peripheral IV or intraosseous access. So you have to have IV access anyway, or intraosseous, you need it for sure. You will give rapid IV fluid bolus, normal saline, okay, and start adrenaline infusion. Adrenaline is essential for treating all aspects of anaphylaxis. Okay. Give IM adrenaline every 5 minutes until adrenaline infusion has been started. IV boluses of adrenaline are not recommended, but may be appropriate in some specialist setting. For example, perioperative while an infusion is set up. Okay, that's very clear. You give high flow oxygen with the preparation for adrenaline IV. You give high flow oxygen. You can titrate it to between 94 to 80 to 98%. Monitor the vital signs, heart rate, blood pressure, pulse oximeter, ECG for cardiac arrhythmia. It's very common with anaphylaxis. Take blood sample for mast cell tryptase, very crucial not to forget. For the adrenaline infusion IV, follow local protocol, or you can follow these steps. Simple way. Peripheral low dose IV adrenaline infusion, that's 1 milligram adrenaline in 100 ml of normal saline. Prime and connect with an infusion pump via a dedicated line. So we have precautions here to follow. If you decided to start adrenaline infusion, and bear in mind that adrenaline infusion, you cannot do that or decide that by yourself. It should be given by expert hands in that, and you have to consult your pediatric consultant before that. Do not piggyback onto another infusion line. So it must be on a separate IV line. Do not piggyback on another infusion line. Do not infuse on the same side as blood pressure cuff, as this will interfere with the infusion and risk for extravasation, and we don't want that to happen. In both adult and children, start from half to 1 ml per kg per hour infusion rate, and titrate according to the clinical response. Continuous monitoring and observation is mandatory. Any increase in the blood pressure is likely to indicate adrenaline overdose. Continue adrenaline infusion and treat ABC symptoms, titrate according to clinical response. We have in here very important notes. IV adrenaline for anaphylaxis to be given only by experienced specialists in an appropriate setting. So it's not your decision as a registrar. Okay. So in here, we have some boxes in here. We read it together. Airway, partial upper airway obstruction stridor. That's need nebulized adrenaline, 5 ml of 1 milligram per ml. So they mentioned the nebulized adrenaline in cases of partial upper airway obstruction in here, which is going with the Green Book guideline. Total upper airway obstruction, expert help needed for difficult airway algorithm. Okay, breathing oxygenation is more important than intubation. So, in breathing issues, do not think straight away for intubation. Whether the oxygenation part is very important than the going straight ahead to intubate. If apneic, bag mask ventilation, consider tracheal intubation, severe or persistent bronchospasm. You may use the nebulized salbutamol and ipratropium with oxygen. Consider IV bolus and or infusion of salbutamol or aminophylline, inhalation anesthesia as well. So you can use inhalation anesthesia as well. For the circulation, give vertebral fluid boluses and titrate to response. The child 10 ml per kg per bolus, adult 500 to 1000 ml per bolus. Use glucose-free crystalloid, for example, Hartmann's solution or plasma light. Large volume may be required, 3 to 5 liter in adult. Place arterial cannula for continuous blood pressure monitoring. Establish central venous access. If refractory to adrenaline infusion, consider adding a second vasopressor in addition to adrenaline. So in the new guideline, they request in cases of refractory anaphylaxis, even after adrenaline infusion, you think about adding any vasopressors available in your workplace, noradrenaline, vasopressin, or metaraminol. Okay, so this is a new piece of information in the recent guideline. You can add it to your knowledge. In patients on beta blocker, consider glucagon because beta blocker side effect, it may cause hypoglycemia. So consider giving glucagon as well. Consider extracorporeal life support in very resistant cases. For cases of cardiac arrest, follow the advanced life support, start chest compression early, use IV or intraosseous adrenaline bolus, aggressive fluid resuscitation, consider prolonged resuscitation or extracorporeal CPR. Okay, guys, we have finished reading and comparing the both guidelines from the Green Book and from the recent resuscitation and Anaphylaxis UK guideline. And we have covered the anaphylaxis management. I wish you find this video is helpful for you. Please like and subscribe for my channel if you don't do so, for more guideline videos in the future. Thank you.